What are some of the worst offenders there? I know that SSRIs certainly wreak havoc in men. Do they also do so in women?
So if you're talking about general sexual dysfunction that can affect a variety of phases, antidepressants, but all psychotropics have all categories of psychotropics. And these days, people aren't just on antidepressants. The SSRIs and SNRIs are probably most well known to cause multi-phase dysfunction. There's differences, though. I mean, that's one of the areas that I consult with a lot because I work closely with psychiatry here, is that not all drugs are the same. It is a class effect, but there are better drugs and then there are other categories, like, for example, bupropion, which is more dopaminergic. It is a different choice for a variety of reasons.
That's Wellbutrin?
That's the brand name for that, is Wellbutrin.
So what within that class of drugs, what are the ones that are more likely to reduce desire?
So the classic SSRIs, most of them fit in that. And they bundle together, or they cluster together somewhere around 35 to 40% of what we call treatment emergent sexual dysfunction. But I want to make a really strong caveat in a moment about this, because there's some new research kind of debunking some of this a little bit. But that said, so the SSRIs, do you want me to use brand names because people know that better,
Sure.
or generics? So
both.
Prozac, Fluoxetine. I'll use
Yep.
both
Yep.
because being mindful of this. Prozac, Fluoxetine, sertraline, Zoloft, Paxil, Paroxetine. Those are the SSRIs, and probably escitalopram, right? Lexapro and citalopram, Celexa.
Yep.
They're all probably similar. That said, I have patients who say, like, I developed low desire on Prozac, or I have difficulty with orgasm on sertraline, but on Paxil, but not on not on Prozac. So we sometimes try a few if I think an SSRI is the best choice.
That's definitely been our experience clinically, is that, there's a class effect, but at the end of the day, it's kind of drug specific. And I always tell patients, look, if you're, because we're not the ones that are prescribing those, we're not psychiatrists, but if your doctor's prescribing you an SSRI or an SNRI, I always say the probability that you're going to get it right on the first one in terms of efficacy and side effects is actually not that high. So you have to be willing to switch drugs to find that right combination of efficacy and avoidance of side effects. And you'll be able to stay within the same class usually, but it's, there seem to be, non-trivial effects.
Right. So again, we're talking about the condition that you're treating it for. Usually it's depression or anxiety or both, right? And then there's the side effects, which amongst them is sexual dysfunction.
Yep.
So then there's another category, the SNRIs, that stands, the serotonergic norepinephrine drugs, which I know you're familiar with. There's more variability in the data on that. So there's duloxetine, there's venlafaxine, which is a Effexor, which is probably the most commonly used one. And then there's Pristiq, which is desvenlafaxine. All of them are probably similar to the SSRIs, but venlafaxine is interesting. At a low dose, it functions more like an SSRI, and that as you kick in above somewhere like 75 up to 75 is probably low. Somewhere over 100 to 150, it functions more like an SNRI. And so teasing out the sexual dysfunction and the dose dependency is a little tricky on that one, but just keep that in mind. And then desvenlafaxine has some data suggesting it's less likely to cause sexual dysfunction. It probably has to do with the chemical composition and how it's different than venlafaxine. Then there's some new drugs. I guess they're not so new anymore. Vilazodone and vortioxetine, which have very unique and different mechanisms. And they seem to be better, right? They're complex serotonergic dopaminergic
Remind me the brand name
transporters.
on those again.
Trentilex and so Vilazodone. I'm doing a blank. We could look that up in a minute.
That's fine.
Yeah, I worked so much with the generics, but Vilazodone is one of them is we'll come back to that. Yeah. So vortioxetine and Vilazodone are newer mechanistic, and they're mixed. They're a little complicated in their mechanism, but the bottom line is they work both with serotonergic transporters, as well as dopaminergic drugs. So it's the multi-receptor factors that, when you're looking at the sexual dysfunction component, you're probably, that's why the theory is that they're better. The best data is actually with Vilazodone. And
best data for fewest sexual side effects.
Lack of sexual dysfunction.
Yep.
The problem with the research on the 3 newest that seem to be the better, that is desvenlafaxine, vortioxetine, and vilazodone, is that in the studies weren't perfect, right? There was a lot of high pre-treatment sexual dysfunction. So when they separate from placebo and not having treatment emergent, it may be the effect of just treating disease state of depression and improving sexual function, which speaks to the point that I told you I wanted to make in a minute about what some of the newer research says about this in general. The other drug is mirtazapine, which is kind of an atypical SSRI. It is very low in sexual dysfunction compared to the other SSRIs, but it has some other problems with side effects. It can be sedating, which is good for people who don't sleep, and there's some weight gain that people report with that, and why that is a little unclear, but probably the dopaminergic component.
So let's assume that this woman is not taking any of those psychotropic meds. Would her being on an oral contraceptive sway?
Yes.
Okay,
Thank you.
So what's the role of oral contraceptives?
Yeah, so I was going to tell you about that in a minute when we talk about hormones and this age, premenopausal women. Let me make my point though, because I don't want to forget.
Okay.
So there's some research that's come out both in menopause for menopausal women and in general that the best thing to do for a depressed person for sexual function is to treat their depression. Right? Mm-hmm. And that probably, and I still am having trouble teasing this out, that probably the best thing to do is pick the best drug for them, for their depression, and that it's more important to get them undepressed in terms of sexual function, and that a small percentage, even though the numbers in other studies say 30 to 40%, will get what's called treatment-emergent sexual dysfunction. But one of my colleagues, who I admire greatly, who does a lot of work in this area, said something to me the other day. We're working on a project, a paper that relates to this. She said, look, the bottom line is, here's the simple answer. If you treat their depression, most likely their sexual function is going to get better. If it doesn't, it's due to the drug. And I thought, and then if they don't want to, it's not because their depression is not better, because depression is associated with sexual dysfunction, right?
That makes sense.
And then that's when you start to say, well, if this is important to that person, you switch the drug around. And this is where we can come in, is where we can say, look, this is an important reason to switch meds, right? But you don't want to, like some people say to me, I don't care. Like, I just am so happy I'm feeling good. And I sometimes say, great. Or sometimes I say, well, you could feel good on something else and still have good sexual dysfunction. Don't dismiss that, right? So it depends on the patient. But now, so the other big category, so we talked about psychotropics, and they're less commonly prescribed in like ordinary situations, but antipsychotics, anxiety meds, they all have some issues around sexual function. And should that be relevant, we could discuss that. So the other categories, like not so much for this woman, blood pressure meds, there's some discussion about how to think about those. There's a collection of pain medications are another big bucket. Hormone-suppressing drugs, like if someone's on a aromatase inhibitor for cancer prophylaxis, et cetera.